Today we will be talking about health information systems, looking at the spectrum from individual patient level data to aggregate data. And that is the session for today, but you should know that the Africa Cancer Control or Cancer Research ECHO, for those who are joining for the first time, is a community of practice that has been going for, I think, over 5 years now, where we have participants, speakers, stakeholders from the whole spectrum of cancer control, from patients themselves to clinicians who treat them, to people who are developing and coming up with innovations to improve delivery of care, to advocates. And we meet every once a month, Thursday afternoon, if you are from where the session is headquartered in Kenya. And we have usually setup is that we have 2 speakers. It could be a little bit more than that, but you have sort of 2 aspects of the presentation: a more didactical presentation, which they will be given by Hamish for about 15 minutes. And then we also have an actual case presentation from the field, which today will be given by Masvita. So those take about 15 minutes each. And then we have a discussion where people who are on the call can provide their insights and they can ask questions. So again, as I mentioned, please remember to mute your microphone so that we don't have a lot of interactions unless you're speaking, in which case you can unmute yourself and ask a question, especially later in the Q&A session. But if your bandwidth allow, you should keep your video on so that we can see you and we see you nodding and giving thumbs up so that the speakers know that you're following. And then please use the chat function at any time so that you can ask questions and give comments. You can enable subtitles if you're having trouble hearing the speakers, if they're having a bit of an accent, like myself. And as I mentioned, the sessions will be recorded so that people can catch up on those. So I will now introduce the speakers for today. The objective of the session is to really discuss the difference between individual level and health information. So individual level and aggregate level information and how that is used to support different aspects of care, especially focusing on cancer control. And then we are going to look at opportunities to connect individual level data to aggregate data collection systems with examples that are coming from the field. Again, my name is John Black Kabuche. I am a medical doctor and a health informatician from Uganda Cancer Institute. I'm also now a postdoctoral researcher at Stockholm University, working with SPIDER, which is the Swedish program for ICT in developing regions. And the speakers are Dr. Hamish Fraser, who is an associate professor of medical science and associate professor of health services, policy and practice at Brown University in Providence, in Rhode Island, in the US. And the case will be given by Dr. Masvita Mchengeti, who is the head of department, National Cancer Registry of South Africa, the principal investigator on IAC Collaborative Center in Johannesburg. So there is a lot more information about their profiles, which was provided in the agenda, and other people are involved in the Africa Cancer ECHO, so you can look at that as well. But without further ado, and I see that we now have a good audience, I will ask you, Hamish, to start. Over to you.
Okay, so change the order, that's fine. All right, so I should be able to share then. Let's see. One second. Yeah, I need to. You should see the title slide. I haven't put it on full screen yet.
They're coming through.
All right. That looks okay. My end, is that good?
Yes.
All right.
Hamish, we're actually seeing your presenter view, not the
right.
flip the screen.
Try that. That better?
Yep.
Okay. Yeah, it's always fun doing that. So I will just give a really brief introduction to some of the key background on OpenMRS and the work that's been done so far on oncology. Now, I realize that many of you know quite a bit about OpenMRS, but probably some of you don't. So I wanted to provide some of that background, and then some of the examples of both things that have been done or that have been planned or designed around OpenMRS and some of the potential there. So first of all, just a few comments. I mean, information systems have obviously become increasingly important around the world, including in low-income countries. And there are a lot of things that we can really do with information systems that can improve quality of care. And that's really been a big focus of my work. And so obviously many of these things are fairly straightforward ideas about direct care, particularly around just the clinical record, but also looking at how we can measure disease burden and monitor processes of care and outcomes, which of course is really hard to do if we don't have effective information systems, and can be particularly an issue with rarer diseases, where we really need to be able to capture a larger group of patients. We've also worked a lot over the years on improving access to radiology imaging, and particularly ordering both medications and diagnostic tests. And these have really been shown in some clinical trials to actually improve quality of care in low-income countries as well as in high-income settings. And in addition, we've looked at a lot of questions around how do we improve alerts and reminders to improve care, including, for example, patient follow-up and compliance with medication regimens, which have obviously got some relevance in this context. And recently, I've been looking particularly at the question of how do we support newer diagnostics at point of care, but linking them to information systems. So just very briefly, this was a long time ago, 20 years ago, we started this process working on systems to support the treatment of drug-resistant tuberculosis, which is a complex chronic disease, a lot of special requirements around drug ordering and management. And this really led to ideas for HIV and then other diseases. And so around 2004, we had a lot of questions about how would we build a system that would actually support a number of areas of healthcare. And at this point, I was working with Partners in Health, healthcare NGO in Boston, and particularly focusing on Haiti, Peru, and Rwanda. And so we actually teamed up with a team from the Regency Institute and AMPAF project in Kenya, Paul Beyondich and Burke Mamlin, and Chris Siebrecht from the South African Medical Research Council at the time. And we really wanted to build a system that would support multiple different countries and languages, different diseases, and really the challenges of limited infrastructure, technical expertise, and of course, rather uncertain funding, not wanting to be the one group responsible for a system that was really supporting many different locations. But in addition, we really wanted to create a different paradigm for this type of work from typical health information systems, where we were sharing best practices and designs, as well as actually be able to build more complex and strategic capabilities in the system, rather than just really a kind of a very basic record. But also, and that's something we've really seen a lot of, building a community around innovation and capacity building, so they could be local ownership of systems in countries around the world. So OpenMRS started in 2004, we started building it. In 2006, we actually first deployed it. And then it was released as an open source project in 2007. And one of the key features is it uses a concept dictionary for data storage, which becomes really important with more complex diseases like cancer. And Andy Cantor, who's on the call here, is actually the guru for this and has been an enormous support for the project. We also obviously support secure logins and security for the system. And it has an unusual architecture where the modular design allows any kind of project to actually build their own modules and plug them in, rather than having to rely on a core team for that. And that's been really important in our ability to build very flexible systems and do things like supporting oncology. Currently, it's hard to know exactly how many people use it. It's in at least 44 countries clinically, so just under 7,000 health facilities that we know of, and 15+ million patients. A lot of those patients and health facilities are primarily caring for HIV patients, but there are a range of other areas. This gives us some idea of the scope of this, and you can see the quite a rapid growth, particularly around HIV care, but also we do see heart disease. There's a specialist version for Ebola when that outbreak occurred, and increasing interest in emergency care, diabetes, and mental health. So, as I said, Andy Cantor on this call, this is really his design, and it's really a fantastic tool which maps the concepts in a concept dictionary, which were designed around the requirements of low-income settings, particularly to the type of mappings we see with Snowbed CT, ICD-10, LOINC, and other coding systems, so that we can actually match those. And I'll come back and comment about some of the work that's going on at Brown University that could be relevant in this as well. The modular architecture, I said, is quite unusual, but it allowed us to be very flexible in the way we build systems. This is some of the newer designs where we have FHIR, this interchange standard or interoperability standard, and also we can support smart modules, which is a system that's being used increasingly in the US. The newer version of OpenMRS 3.0 has a lot of focus on the user interface and newer versions of these tools. But the core platform is really the data model and the APIs, which means that it can be used in a lot of situations, either with the OpenMRS front end or with other front ends that have been attached to that, which can be very helpful. Just a brief call out to John Black, to your country. This is the largest meeting we ever had, which was actually in Uganda. And Uganda at this point has the largest current rollout of OpenMRS of about 1,300 sites. And is still expanding on that. So each of those sites has a separate instance of OpenMRS, whereas other countries, for example, in Kenya, the AMPA project, the sites are actually managed from a cloud-based system based in servers in Eldoret. So there's both of those paradigms exist. And this is just a kind of schema looking at some of the ways in which electronic health record systems, such as OpenMRS, can be linked to other systems that are really of importance, particularly in hospital settings. And these are the kind of the standards we're using. So currently HL7 2.x is often used for lab data and pharmacy data and various other areas, but increasingly we're moving to HL7 FHIR. There's also ways of exporting data to both DHIS2, the national reporting system used in, I think, about 80 countries now, and also disease surveillance and systems and data warehouses. And then, of course, links to various mobile health systems, including ComCare, Community Health Toolkit, OpenSRP, which is the WHO-supported system, ODK, and others. And then a couple of different radiology PACS systems are also linked in different contexts. BAMNI is an example where ThoughtWorks Inc. took the OpenMRS core system and modified it with a new user interface, and then linked it to 3 other systems, Enterprise Resource Planning System called UDU, DCM for CHI, which is a DICOM compliant PACS system, and OpenLS, which is an open source lab system. I won't go into great detail, but just we have a lot of support for HL7 FHIR in the newer versions, and this is something which could be really helpful in linking particularly to newer systems for diagnostics, better ways of exchanging data between information systems. And for example, we're working on a different project with neonatal care, using it to export neonatal ICU data to the Vermont Oxford Network Registry. And OpenHIM is Open Health Information Mediator, again, something that Andy better qualified than me to talk about, which is really a critical component in building interoperable health information systems, developed by Chris Siebrecht's team at Djembe Health Systems in South Africa, primarily. Excuse me. The other aspect of this work is that there are a lot of other open source systems that are currently being used in health contexts around the world. And each of these systems has been certified as open source. And in many cases, they're able to interoperate or to be connected to build more complex systems. And so there are electronic health records like OpenMRS, but also various mHealth systems, surveillance systems, pharmacy management, and so on. And these are all supported by Digital Square with some funding, particularly for projects which provide kind of common good between them. And so there's a lot of things we can build on here in creating more effective health information systems. Just briefly, this is Rwanda. I just put this up to show you these are sites that are running OpenMRS, and the ones here in green are actually around Butaro Hospital, which is one of the Partners in Health supported hospitals that has a cancer center. And when that was started, about 2011, we started building an oncology version of OpenMRS, and that was actually first deployed there. So that was actually 2012 when it was actually deployed, partner between the Rwandan Ministry of Health and the Dana-Farber Cancer Center, as well as Partners in Health. And so this really was primarily a simple clinical record plus a more complex system for doing chemotherapy templating and prescribing. And that system has continued to be used pretty extensively in Rwanda and in the Mira Valley Hospital in Haiti, but not really anywhere else, I think, at the moment, although I don't know the whole story here. So there may be other people doing that, but there's been a lot of interest in how we can actually build on that, particularly with newer chemotherapy templates. These are some numbers from Dave DeSimon, who's on the call, and he's one of the key people at Partners in Health supporting this. So hopefully Dave will be able to comment on my what I'm describing here. But as you can see, there's a fair number of patients from 2013, and this is from Haiti, from the University Hospital Mira Valley. So quite a significant use over the years, but still relatively simple, just some additional improvements in around capturing certain aspects of the history. And also there was some work carried out in about 2018 with IBM to look at improving the development of chemotherapy ordering and templating, among other things. But those designs, well, I think, quite promising. There wasn't really resources to operationalize them yet. This is a description of that work that John Black, of course, wrote, so I won't go any further with that. So one of the reasons why I'm particularly interested in this at the moment is that I'm working on a project at Ampath using machine learning to improve follow-up of patients with HIV. And so we were out there in January, and the oncology team there are very keen on developing or getting a new oncology EHR system. They have actually one of the largest oncology centers in East Africa at this point, and really need a much more effective system, and are using quite a lot more complex regimens for chemotherapy than the original ones that the PH supported. So that's really one of the areas that there's potential for collaboration. And from that, we started to look at what were the requirements there. So they have a ERP system which manages some of the things like drug supply management and so on, but only a very simple EHR component of that. So there is interest in this, but I think it's like all these projects, putting together a series of groups with some funding would definitely be the way to go forward with this. I mean, I think it's a very exciting project, but it's not something that can be done just very quickly. I'd also say that Brown University, we have a new professor, Jeremy Warner, who just moved from Vanderbilt, and one of his areas of expertise is actually building ontologies for cancer care. I was going to say ontologies for oncology, but that seems a bit of a mouthful. And so their group is also interested potentially in being able to support this work. And that would kind of, potentially fit quite well with the work that Andy is doing. So there's finally, this is OpenMRS 3.0, which is a new, much slicker version of OpenMRS, particularly the interface, designed using IBM Carbon design system and micro front ends approach. So it has a much more flexible user interface, and it also provides better support for data exports and analysis, and particularly led by Ian Backer in my team, strong support for HL7 Fire. So we're in the process of piloting this, but it will provide a much more sophisticated set of tools for building more effective and usable tools such as order entry systems. And this is just an example of one of the early versions of this with drug order entries in the 3.0 system. And then finally, I just want to mention that the work we're doing with Ampath is actually part of an R01 from NAID, looking at how we can use machine learning to predict loss to follow-up and then to develop more advanced decision support tools based on that, and then evaluate them both qualitatively and then in a larger clinical trial to look at how we can improve care. And we'll be looking at both loss to follow-up and virologic failure. And so while this is not directly relevant to cancer, the tools we're building will probably be quite valuable in this context and some of the experience we're getting there. And I see I'm at my time, so I will leave it there. And as I said, there are other people with great expertise, and of course, John Black, but also Andy and Dave. So feel free to update me on that.
Thank you so much, Hamish, for this feels less didactical and more concrete. But I think that's good because people want to see what's happening out there as well as the impact. So looking at the numbers coming from Haiti, I think that's helpful. Please put questions in the chat for Hamish or for others in the call. And I want us to go to the next speaker, and then we can have the questions and answer session at the end. So the next speaker is going to be Masvita from South Africa, and she will be looking more on the aggregate side of things. So of course, data begins as individual level data and goes to the aggregate for disease surveillance, for forecasting, and she'll talk about that from the cancer registry side. And I think then we can begin to connect the dots of how data begins from the patient side and how it supports the aggregate and population level. So Masvita, I see your slides are on. I'll let you take it away.
Can you hear me? And can you see my slides?
Yes, we hear you, and the slides are visible.
Okay. I'm just going to share our experience in South Africa in terms of using cancer surveillance data and the cancer surveillance systems that we have at the National Cancer Registry of South Africa. As John Black said, I'm the head of department of the National Cancer Registry, and my name is Masvita Mchengeti. Okay. Okay, my slides are not moving, not sure why. All right, okay. Just an overview of the National Cancer Registry. So our functions include cancer surveillance, research and training, cancer awareness, and generating evidence to inform cancer policies. And these functions are governed by a cancer registration law, which is called Regulation 380 of the National Health Act. And we have a pathology-based registry, which was started in 1986. And this is fed by a laboratory system. We also have a population-based registry. So these are sentinel sites where we are actively collecting data. The pathology-based is a passive surveillance system, where we are getting all our data from a laboratory system. We have a childhood cancer registry, which uses both the pathology registry and also active reports from pediatric oncologists from all over the country. Then we also have a research and training division where we are training masters and PhD students who are studying cancer epidemiology. In terms of data management flow of our pathology-based registry, we have both starting from the first point here, we have electronic data coming from both private and public laboratories that is sent to a central data warehouse, which is the NHLS corporate data warehouse. And these, we pull out cancer reports using SNOMED codes and also using text mining for words that are commonly used for cancer. And we pull the data into the NCR server. The reports are then coded using ICD-03 through an app. The app automatically downloads those reports, then they are coded. Then quality control and QA/QC of the coded reports is done. Then we prepare an annual cancer incidence report, and this data is put on the website. Our denominators are the Statistics South Africa media population, and this database is then merged with the full database from since 1986, so that if there are any duplicates, they are removed, and we also do data cleaning. This laboratory system is called TrackCare. So this system is primarily made for clinicians to be able to access the full patient record. So clinicians, they log in using their health professions council as the username, and they create their own password, and that in that way they can be able to see the full laboratory record of a particular patient. They can search using names or ID number, or they can also search using an episode number, which is an episode is when they a particular hospital visit. So all tests related to that visit can be associated together using an episode number. So sometimes they use an episode number to look. So this is the system where clinicians are now accessing. The same system also has a portal where clinicians can also download dashboards. So they are not dashboards for cancer, but for infectious diseases like HIV, they can download dashboards to, for example, that from their own facility to see, for example, if there's no HIV suppression in terms of viral load, and they get alerts. They can get alerts from the same laboratory system. In terms of our Sentinel sites, these are population-based cancer registry. We have Sentinel sites in 2 provinces, in Gauteng and KwaZulu-Natal. They have distinct denominators, and we have active surveillance of nurses going in there as surveillance officers to actually manually collect data, and we put it on a RedCap database. This is to make up for the cancers that are not diagnosed, by pathological means. In terms of the population-based registry, the data flow is similar. The nurses go and extract data from clinical records, radiology. They go to the mortuary. They also we pull out data from our lab system and also give them, and they also go to look at pharmacy records. And then they complete the legislated cancer registry form, ICD-03 coding, and they capture, they do quality control and assurance. Then we prepare the report and we put the report on our website. For childhood cancer, we pull data from the laboratory system that I've just described, but we also get notifications directly from pediatric oncologists, and they email them to a central email. And we also get some childhood cancer from the Ekruleni, the population-based, and we collate all these and then go through the same process of QA/QC, combining records, deduplication, and preparing the report and putting it on the website. We also use this laboratory resource for research. For example, with the South African HIV cancer match study, it's a laboratory cohort of South Africans living with HIV. So this is anyone who has ever accessed the laboratory system for HIV monitoring or diagnosis. So for the period 2004 to 2014, we pulled out 52 million HIV tests, CD4 counts, viral load, and RNA tests, and we linked them to 665,000 cancer records. We used probabilistic record linkage because there's not always a unique identifier. While ID number is sometimes captured, most of the times it is not. So in this system, we used episode number. This is for this shows a particular hospital visit. We encrypted names. We used birth date, age, sex, district and sub-district, and we linked that to the same demographic features in the cancer data so that we could identify people living with HIV, with both HIV and cancer, and understand the patterns of cancer in people living with HIV and how they compare to the general population. So this work is published, although now the cohort has been updated up to 2019, the published paper goes up to 2014 and describes the methods. Thank you very much for your attention. This is the National Cancer Registry team. Over to you, John Black.
Thank you so much, Basmita, for this overview of what happens at the Cancer Registry. Yeah, you're right on time. I think now we can begin to discuss. I see that there is a connection. There's, I think, areas of overlap with the work that that Hamish talked about. So there were issues around coding and using dictionaries, which of course are important for you to identify. I saw that one of the workflows involves, coding of the diagnosis, and there's also issues like unique identification of patients that you can really count. And there's always the role of the registration modules or master patient indices, if you may. So, but I want to open this to the participants in the audience. Feel free to raise your hand, unmute, or type in the chat if you need more clarification, if you have a specific question, or if you want to share your own experience with any of these systems that have been discussed. It looks like there's so many things, and you can just pick. It's like Lego bricks out there, and then you pick and you build your own version depending on your need. And sometimes people are used to, they download one executable file and it has the things that they want to do, and it does that out of the box. But here it looks like you have to do a bit of your own, make your own sandwich thing. So questions from the audience. I hope it's not me who is excited by this presentation. I hope everyone else is excited and has as many questions as I have, but I don't want to overshadow. But as I wait, I can, I see Trishi already has a hand up. Please unmute and give your contribution. You can also tell us about your work with the Clever Charts.
Yeah, thank you so much, John Black. Can you hear me, first of all?
Yes.
Okay, perfect. So first of all, thank you as well, John Black, for reaching out. I wasn't aware of this meeting, so I'm very grateful to have been given an invite to it and to hear of all the amazing work that's going around. Just to briefly introduce who I am. I'm Irish. I'm actually in Ireland at the moment, but I'm normally in Tanzania. I've been there for 17 years, and I'm a children's cancer specialist based in Dar es Salaam. But over the last over a decade, we have built the National Children's Cancer Network, basically connecting all the hospitals around Tanzania that are caring for children with cancer. So specifically, my work is obviously with children. And I set up an organization with some colleagues called Tumaini la Maisha, which means a hope for life. And basically, one of the main things we do is we pay for chemotherapy for every child in the country. But one of the other things that we have done, and Hamish, your presentation was amazing. It's unfortunately probably 10 years too late for me. I wish I had met you 10 years ago, because we have just built our electronic medical record system for the country of Tanzania for children's cancer services. And we've called it Clever Cancer, we've called it Clever Charts as part of a suite of Clever Cancer Care. We're also about 3/4 of the way building an electronic automated chemotherapy prescribing tool. We'd be very happy to share with anybody who wants to look at it. Obviously, I had heard of the OpenMRS work, but the data engineers that I worked with just went down a different path. But as I say, if I had met you 10 years ago, we probably would have done it a different way. But nothing that we've built is supposed to make money. It's also supposed to be to try and help vulnerable children specifically, obviously, to access better care through better data and through better diagnostics and better prescriptions and things like that. So as I say, if people on the call are interested in having a look at what we're doing, I'm certainly not trying to hijack this meeting. I think the work that you're doing is extraordinary. As I say, I'm only sorry I didn't meet you a while ago.
Well, thank you for those comments, and really exciting what you were doing. So that's why I think I found you Googling for work on cancer from Ocean Road Cancer Centre, because I know there'd been some interest in this work a long time ago there.
Yes.
So,
yes, I started in Ocean Road. Yeah.
So it was exciting to see the progress you're making, and you know the whole philosophy of what we do is it's all open, so people can take the system or any part they like, and they can redo it in any way they want. Obviously, it tends to be helpful to try and share as much as possible of the code because it saves time, but you know, there's opportunities for sharing designs, and also with order entry systems, they aren't integrated fully into an EHR. They're a separate system really, and we'll often talk to different EHRs. So there might be some opportunities there too.
Absolutely. I was excited to hear about that. Yeah. So the order entry system would definitely be something we haven't tackled yet. So that would definitely be super helpful. And the other way around, if there's anything that we have done, I mean, I'd be really happy to just show you what we've done. If any of it makes your job easier, we're also the exact same. We're kind of on your model. We want to do the same. So
thank you. No, we'll look forward to trying to set that up. That would be really good. And I do have a number of colleagues in Tanzania. So I'm sure there'll be opportunities to visit as well.
Well, this is very nice for the meeting. I think for ECHO, this is what we want to have. We want a community of practice that grows and people share insights and resources. I also know that every time we're discussing cancer care in children and all these interventions, at least the head of cancer, pediatric oncology at the UCI is already saying pediatric oncology gets forgotten. People don't think about that, because it's a small number. It's about 10% of all the cancer patients that we see. So it's thought about last, but there are some unique things about pediatric cancers that you want to look at. And also for the registry, for example, you might not find out of risk factors that you collect. In the registry, we are looking for things like smoking and other exposures, which might not necessarily apply for pediatrics. But of course,
we don't tend to collect that data.
Exactly. But that means that when you're designing a system, an information system, you want to consider these unique issues about the disease and the population, and also the things that are important for pediatric care, things like vaccinations and growth monitoring and all those things that are important that might be forgotten if you're designing a cancer system that is focused on chemotherapy and all the toxicity and all that. So very nice that we're having these discussions.
And John Black, maybe just to say one of the particular things that we have focused on is nutrition. We have a really complicated in the background, but a really nice way of collecting data on nutrition and also kind of prescribing nutrition for children who are struggling. And I'm sure that could be used for adults as well. So there's things like that I think we've done quite well.
Yeah, indeed. So I don't know if I'm missing some questions in the chat. I see that Andy has been sharing about the issue of concept dictionary and the mappings that are important. And I see maybe one of the usual limitations that I point out. For example, he says that SEAL, which is the concept dictionary in OpenMRS that tries to standardize every bit of data that you collect. If you collect age, it is well defined and it can be understood by another system, and there's no errors in computation if you collect a diagnosis. But I see that he mentions that currently it doesn't, it's not mapped very well to ICD-O, which is the oncology subset of ICD-10 or ICD-11. And I remember this was an issue for us, for example, when we got commercial EHR or ERP at the UCI called Clinic Master that, for example, would want to document, the cancer diagnosis, and then someone will begin to type in, let's say, prostate cancer, and then it will give you a list that includes, let's say, prostatitis and TB of the prostate and all the other prostate things that can go on. And sometimes the person who's entering data is something happens and they by mistake enter TB of the prostate, for example. And then you have that in the field for cancer diagnosis. And of course, that throws everything off the rails, because you are expecting that this field will capture cancer diagnosis, and now it has TB of the prostate. And so if you would constrain that to, ICD-O, then you reduce this mental burden of the person entering data to have to check that they're not entering some other prostate issue that is not cancer of the prostate. So these are important things to look into, but I also understand that I think we're sort of getting more specialized with time. So we go from the bigger issues, and then we begin to go into the oncology subset. I think these meetings like these are a good way to start. I don't know if there are questions before I take over the whole discussion, because I'm too excited about it. I don't see much in the chat.
Could I maybe ask Dave,
if
Dave, would you have any comments about the way that the system for OpenMRS for oncology at PH is being used at the moment, and some of the questions that you have for moving that forward?
Sure. So, hi everyone. Again, my name is Dave DeSimone. I'm a software analyst and EMR implementer for Partners in Health. So I'm not quite as familiar with our EHR implementation in Rwanda as I am in Haiti. So in Haiti, for instance, we do capture, well, in both places, every oncology patient is registered. We know where they're coming from. We know when they visit the facility. We have all that electronically. We generally capture history for patients electronically. In Haiti, we don't do quite as much in terms of recording the orders. We do some work in recording medication orders in our implementation in Haiti, but not so much for oncology, as I'm sure many people on the call know better than I do. Chemotherapy orders can be quite complicated. So we don't do quite as much work there in Haiti. I believe in Rwanda, we do a good bit of work capturing chemotherapy ordering. And we also, in both places, I believe we capture when treatment is given, like once the orders are placed, when they're administered. And then we do our best to then track outcomes and longitudinally patients over time. That can be, I would say, maybe a larger challenge than you might expect, but yeah, I mean that's basically it. We're continually trying to improve. I know in Rwanda they've done some recent work in improving the electronic patient chart, leveraging some of the work done in OpenMRS3 that Hamish had mentioned earlier. And I think that's really, I would say that's the platform that offers us the best opportunities for growth and expansion right now. It's kind of an exciting time in the OpenMRS community right now with this OpenMRS3 initiative. And I would think any improvements we make for oncology care would be done in the OpenMRS3 platform. Yeah, so I'm hoping that we can get some collaboration together and work on that platform to build out a much more robust oncology module than what we have now. I mean, I would say that just one last thing. I think the thing we haven't done is really done a lot of work collaborating across organizations in OpenMRS on an oncology module. We kind of have, actually at PIH, we have actually 2 versions of the oncology module, which is less than ideal. So it would be great if we could kind of collaborate with other organizations and really combine our efforts to build a robust oncology module in OpenMRS.
Indeed, that also comes in given that sometimes, like for example, pediatric, you might not have so many cases. So if you're trying to find evidence of impact, you might want to combine cases across hospitals, across even borders of countries, so that you can derive insights. And I think this is also what the OMAP work that Hamish talked about is focusing on. And I see that NEGA is also around, and we've been discussing this, getting this observation data across systems and put them into one data, one repository, and then try to draw insights across So I think that is very important, and I hope we can share contacts from here and we can follow up on these discussions. I don't know if there are questions, but I wanted to ask a few questions that I put down. One coming from the question of impact, and it gets we're excited about this, and I've seen a paper, for example, by Masvita. I wrote a paper about the development of the sort of the designs that we're working on with IBM, but then we didn't really see that coming to clinical application. And here we have clinicians who are waiting to see, okay, so what do all these things do for the patient in the end? Are we saving more lives, or is that too far? Do we have maybe some intermediate processes where we say, for example, we're having more adherence to treatment, and we can show that evidence? Have we done studies to show that? Or do we have a reduction in medication errors? Do we have some evidence for that? Do we have even improvement in the clinician's experience, that they now don't spend so much time seeing a patient because there is a tool that they can use to prescribe? I'm putting this back to to you, Hamish, to Masvita, to Trishi, or anyone who has some experience on this, because I think this is the curve that we need to give the clinicians to overcome the inertia, and for them to care a little bit about these systems.
John Black, can I respond?
Yes, please.
So a couple of thoughts here. I mean, first of all, there's clearly a lot of important design work in the key components that we most supportive for oncology care in low and middle income countries. And obviously we can learn lessons from higher income settings, but the complexities of EHR systems used in the US or in other high income countries tend to be somewhat prohibitive for the sort of work we're doing. So I don't think it's easy to transport those systems directly. However, in conversations we've had over the years, really from 2011 onwards, the importance of chemotherapy prescribing and the templates for that seems to be a very, very common core thing that also came out in the conversations with the oncology team in Eldoret, and with others I've spoken to. And I'm sure you're all very familiar with this, but as more complex regimens are being used, for example, in Eldoret, they have quite a lot more types of chemotherapy agents available than they were originally in Rwanda. Building that piece could both improve the speed and efficiency a huge amount, because it's very complicated, obviously, to fill these things out by hand, but also reduce the risk of errors and improve quality of care. And there's pretty strong evidence that would happen if we did it right, given other studies in other countries. And also, just sort of to follow your point about ensuring we actually have an impact. I mean, I didn't show the slides about all my work, which is on evaluation and looking to try and improve the quality of care, and also to be able to demonstrate that. But it's certainly would be a key component of any work we do going forward, would be to carefully evaluate both at the kind of the preclinical usability side, initial deployment, to make sure that people can really use it effectively, as we're currently doing with OpenMRS 3.0, and then building on that work to really assess in a larger study whether the system is actually improving care. So very similar to what we're trying to do around HIV care and other diseases. So I think, I mean, this looks like a sort of a larger both research and implementation agenda. I mean, obviously the most important thing is improving care, but to get there, I think we need to identify sort of the most valuable components which we can add to OpenMRS or other EHR systems. So I think we have a lot of expertise here, and also other collaborators who could do that, but clearly this needs some kind of funding to pull that consortium together, because we lots of great people, lots of great ideas, but there actually is quite a bit of work to do, both in the design and also, of course, the software.
Yeah, thanks. I saw that Nadine raised her hand, and then Masvita. So Nadine, can you comment on this issue? And Masvita will also comment, and then Trishi.
Yes, hi everyone. I just heard about this call, so I decided to join in, even if it's a bit late. I'm Nadine Karima, I'm the Deputy Executive Director for Partners in Health in Rwanda. I just wanted to complement some of what Hamish and Dave have said about the use of OpenMRS for oncology in Rwanda. Yes, we've done a lot of work for chemo administration. and it has saved a lot of the time from the clinicians, but unfortunately, we haven't been able to do a study and quantify that. And we're still facing some challenges because it's been a learning curve for some of the clinicians who started a long time ago, who were used to more of a paper-based and less stringent protocols in terms of care. But I definitely agree that we need to do more studies around that. And one additional aspect that we've been focusing on is decision-making support in terms of reports. So the clinicians get some reports on what patients are coming for the day, what patients are lost to follow up. And that has definitely helped improving in terms of keeping track of their patients, especially that the region where the Butaro Cancer Center is at the border with Uganda, between Rwanda and Uganda, and we also received some patients from Burundi and Congo. So it's been easy to know what patients need a call in terms of remembering adherence and coming back for their appointments. And we, as a next step, we're trying to invest in SMS-based generated SMS for from OpenMRS to kind of send reminders to patients when they have an upcoming appointment or when they've missed their appointment. Our team is currently working on that. And in addition to that, I just wanted to bring up the fact that we did realize that, and this is true in most LMCs, most patients present late for care. So we're trying to also invest more on early detection. And we've been using Muzima that's been developed in Kenya for screening patients for cancer, linking their information into the hospital's EMR for referral, and trying to take a tab, to keep tab on whether they showed up once their results are positive. And we think that it will be a game changer when we get the SMS reminders and notifications enabled, so that we can, save more lives. And again, we tend to not think about like studying that and studying the impact, but I think through this call, I'm being reminded that we need to focus more on that as we improve a patient's life. Thank you. I don't know, Regis has also been working a lot in Butaro around that area. Regis, if there's something you can add to that, feel free.
Thank you, Nadine. Yes, we need to have these evaluation studies, because we need to convince the clinician that that these things are worth the investment. Also, the people who are putting in the money, the managers and the donors and everyone who is involved. So maybe now is the time to call for us to jointly write some grants. But yes, Masvita, you wanted to comment on this issue, the evidence. You showed us one paper that you published about this. Go ahead.
So in terms of the information systems and how they would benefit clinicians, most of the applications that we have used have been in infectious disease. So the cancer registry is nested within the national labs. So that means even infectious disease also falls under national labs. So for example, during COVID, we had e-notifications. If you had a positive test, then you could get the result, on SMS. But that could be leveraged, to just when people have abnormal pap smears, to say, please go to clinic X to see your health worker. Of course, you cannot give cancer information on SMS, but at least you can just nudge them to go to the clinic, and they can go to the clinic. We also have alerts for like notifiable medical conditions like measles and COVID and TB. If there is a positive result in the lab system automatically triggers an alert to start an outbreak investigation, particularly for like cholera, the ones that need to be notified within 24 hours. Which are urgent. So we need to think of ways to leverage what has been used for infectious disease in order to use the same information systems to benefit cancer. Particularly, we have started doing some work on an inherited cancers database. So in South Africa, we do have a problem of cancers occurring in clusters in families, like breast and colorectal cancer and uterine sometimes occur in clusters. So it is important for the clinician to actually know that there are other people in this patient's family who have had other cancers. And sometimes it's very difficult for a patient to articulate that, my dad or my uncle or my mom, my aunt has had this kind of cancer. But if the clinician can then use the lab system to track that, it can be a way. It can be a way of helping the patient, the clinician, and to have this family-oriented care in families where they are, familiar with cancers. So, and with regard to the HIV linkage study, we just not having the issue of not having a unique identifier has necessitated this probabilistic record linkage, which takes a lot of time. It's time consuming because of the lack of. It actually shows why we need these information systems, because if we had a centralized information system, we wouldn't have needed to do a probabilistic record linkage. We could just pull all the HIV, because we have a lab system that is testing everything. HIV and cancer is all being tested within the same lab system, but we have to do probabilistic record linkage because we lack this information system. If we had the system that John Black, that Hamish is talking about, we wouldn't have to do this linkage. But still, despite that, we were able to see which are the HIV-associated cancers in South Africa, how are they differing, and how the treatment of HIV has affected the cancer epidemiology in South Africa. Thank you.
Yeah, very, very pertinent issues here around identification and master patient indices. We are struggling with that as well. And I know that, for example, getting data into CANREG involves a lot of this filtering, seeing deciding if a person called this name is actually different from the other person. And I think this is something that we all have to sort of work towards. There are some initiatives that are going on, for example, national ID databases. These are not as good as they are in the Western world, where, for example, you have a social security number in the US, or the personal number in Sweden, for example, which is centrally managed by the government, and you can use that. But even then, there is also other issues like GDPR, data sharing laws that can prevent the sharing of information. So I wanted to hear some comments on that. But I want to first allow Trish to comment about this issue. She's had her hand up, and I do have some follow-up questions for her. So, Trish.
Thank you so much. I just wanted to comment on the, getting the clinicians interested in this. I can guarantee you they are interested. One of the things that we did before we started, so we haven't quite got our online chemotherapy prescribing tool ready yet, but in the meantime, for the last about 4 or 5 years, we've used an Excel-based version, which basically we built these very complicated Excel sheets for each of the diagnoses. And before we did that, we reviewed the children's prescriptions versus the protocols, and every single one of them had an error in them. Now, some of the errors were omissions. They decide, there wasn't a routine of doing a certain blood test or a certain scan or whatever. But as per protocol, every single one of them had an issue if you were going to go by protocol. And by moving them to the Excel-based system, we were able to basically free up an awful lot of time that the clinicians were doing actually prescribing and calculating and looking up. They were literally just had to put in a few of the children's routine things and a few bloods, and the Excel sheet did everything else, including swapping out drugs if a child had cardiac issues or renal issues. And within a week, clinicians would not go back to writing chemo. So you will have buy-in if this is written correctly. So I just want to reassure you, this work will definitely be adopted.
Yeah, Actually, my question to you that was to follow up was about exactly that, because I was thinking many times when you look at, for example, if you look at what Hamish presented, there is like a whole suite of systems that you have to put up, you install this component and then this component, and it becomes so hard for a person to jump in. It's intimidating. So I was thinking, are there simpler solutions that people can get, you know? And I've had clinicians ask me this, and I just get a thing that helps me to schedule my patients before I deal with all the other issues of chemotherapy and getting radiology images and getting, you know, data to the registry. Can I just deal with scheduling only? And I know that Hamish talked about the modularity of OpenMRS, but I don't know if that modularity is at this level of, there's a thing that I can just download, or I don't know, like an Excel formula thingy that Trish is talking about, and I deal with chemotherapy. And maybe now I want to deal with scheduling. Maybe I want to automate reminders to people that have screened. Is there a simpler tool that I can use for that? And I don't know if you have more comments on this.
Well, I think the point is, and I'm not going to speak for Hamish, but I imagine it's something similar, is that if you build a comprehensive tool and then people can take the various bits that they find most useful, if their hospital already has, you know, a lab system and a radiology system, then the comprehensive system with the lab and the radiology bit doesn't need to be used. But if you need a planning, you know, appointments planning, and you need, as we said, chemo prescribing or chemo ordering, if the system has all of those tools, then each of the various different players can choose which bits are useful to them. That's what I think. But it's very important that they have some system to track the patients and make sure, you know, the diagnosis and the stage and the follow-up and all of that is being done correctly. And I think one of the things which I'm sure you're doing, which is at every step just working with the clinicians to make sure, because as you say, I would maybe advocate that cancer care is probably a deal more complicated because we have so many other subspecialists and so many other drugs than, say, HIV care. So it's really important that the clinicians are part of the kind of the creation of it and the kind of the feel for it and the flow of it, so that they feel that it's familiar to them, you know.
Hamish, you have your hand up. You mute and comment on this. You're still muted now.
Yep. Thank you, Trish. These are really fascinating and very helpful comments. I mean, I think that as a clinician by training, I mean, certainly the critical issue here is building tools that are really helping to provide effective and high quality care, and also the time involved in effectively prescribing chemotherapy and the detail orientated nature of that means that it obviously is very valuable if you can automate some of those processes. I mean, I think one of the things we're trying to do is, of course, to build reusable components, and they don't have to be one system. So we can, you know, obviously already you have systems like OpenMRS and other EHRs that will talk to systems of labs and for drug management, and as I said, for order entry. The system we call the point of care system in AMPATH for HIV care was developed by my colleague Jonathan Dick and a team at Eldoret, and they actually put the whole front end and all the tools and decision support onto a separate server, and that server calls data from the back end of OpenMRS. So it actually uses a slightly different way of designing it, and it's something that we've made more flexible with the newer version of OpenMRS, the 3.0, so that you can potentially have a server which is going to support all of the chemotherapy order entry, but which is then called to actually use for a particular hospital, without having it be sort of tightly integrated within the EHR. So I feel like, and I'm not an architect here, so I'll have to refer to my colleagues like Ian, who works with me, and the others, but I think there's some opportunities here for building a component which would be reusable in more than one health information system. You know, it's not just tied to one system like OpenMRS, and would obviously build on things like the ontology for oncology that we're talking about. It would also build on the workflows and the designs and the experience that you have, Trish, you know, in terms of what you've learned that works well, and obviously the things that other people use. And so, you know, the great benefit here obviously is you can start to have a community who are working with this and saying, well, actually we need to improve this, or we've got this new drug and we're using it differently. Let's build another profile, and other people will then add that to the system. So I think there is a way of doing this that doesn't require like one massive project, but if it requires an initial piece of work, but then can be updated by a community going forward. So I'm kind of excited about that. I think one of the other pieces that maybe is relevant to this conversation is that there's very few systems for primary care electronic health records in low-income settings. And this is something I've been really aware of over the last few years, and we've been looking at this question. So chronic diseases like HIV and TB, could be maternal child health care is also well supported. There's lots of work around NCDs in some areas, but just basic primary care, the day-to-day visits, the very quick visits, the emergency care visits, very few of those are documented effectively. And that produces a real problem when it comes to early diagnosis and screening, because of course you don't have the data or access to who came in with this potential cancer diagnosis or symptoms. And I think that's going to be a piece that it's important for a whole bunch of things. And it's obviously really important for disease surveillance in infectious disease context. So it's something which we really want to see moving forward. But there is some early work going on in India and a couple of other areas where people are building these tools, but it's still a bit of a gap, I think, particularly in the surveillance side of things.
Yeah. Thanks. Misha, how are we doing on time? I don't want to keep folks longer, but because I'm seeing some people leaving, but this is, I think, a very interesting topic. Do we have some minutes?
We do still have until 30 minutes past the hour. So yes,
Right.
this has moved to a 90-minute slot because of this reason, to allow for extension.
So I do have another general question about this. So in terms of barrier to entry, of course, having a simpler system that is easy to get, that addresses a very real immediate need of the clinician, as opposed to, for example, aggregating data that might seem a bit distant. Those are important issues. But there is also the issue of training. We're talking about clinicians who are trained to deal with patients and give injections and blood and all that. And now we're dealing with fairly technical things. We're talking about servers and pathologies and all these things. These are not things that clinicians are familiar with. Even coding of diseases, I think maybe in the US you even have like a special training for medical coders, but we don't have that. In medical school, I think I glanced about ICD-10 in passing in a module somewhere in my second year. How is the training done? There is also, of course, like OpenMRS University somewhere or OpenHIE University. How is the training done? We can begin with you, Masvita. How do you train the people who are getting data into the system? Then we can also have some comments about training, maybe from you, Hamish. How can we make sure that the clinicians, the nurse, the doctor understand what is going on? They understand the implications of these systems and how they can use them. Masvita, you want to comment on this?
So we use the ICD-03, the International Classification for Diseases for Oncology, 3rd edition. It's a subset of ICD-10. But our reports, when they come through the electronic system, sometimes the coding has already been put there, but we still have our professional coders read the report and code it again, because sometimes the code that the clinicians have put in is not the correct code if you actually follow the rules of the ICD-03. So our coders are actually trained through the African Cancer Registry Network. So some of you know Anne Correa. So she's the collaborating center for the IAC-GICR Collaborating Center for Cancer Registry Training in Sub-Saharan Africa. So for English-speaking Africa. So South Africa and everyone else in Southern East Africa, Anne is doing the training. We also have had the team from IAC come to South Africa to train our whole team on ICD-03. So there's ongoing training from the African Cancer Registry Network through IAC to keep our coders abreast. But many of our coders have been working for more than 10, 15 years. So they literally know that purple book off the top of their heads. But that's where we get training. And I also think that it would be nice for clinicians to know how to code, but we don't expect them to code like cancer coders. So we will still do the coding again. Yes.
Yeah. Is there increasing opportunity for automation with artificial intelligence, with all these fancy AI tools that can read and understand understand in quotations?
So currently they actually read manually, and they have a drop-down menu so that they don't put codes that don't exist, which is updated as the ICD-03 adds all those. It's always having revisions, so it's updated. The database is updated. But what we have done before, we have been able to use text mining to extract Gleason score from pathology reports. So in principle, it is something that's not impossible, because at least we demonstrated a proof of principle by extracting Gleason score. It was for a research study from prostate cancer reports. So, and we also managed to extract schistosomiasis status, also for a research on cervical cancer screening, cytology and histology. We looked for calcified cystosoma on the smear, so that whether we were trying to understand whether schistosomiasis contributes to early cervical cancer, because we were having like quite some people getting cervical cancer when they're quite young, in early 20s, and we were trying to understand what were the reasons for getting cervical cancer so young. So we're able to extract schistosomiasis status from pathology reports using text mining. So in principle, it is something that we are yet to try, but I think that it's not impossible to do. But it would have to be cancer by cancer. Yeah.
Right. So individualized models for each disease. Hamish, do you want to comment on the training? How do we get the clinicians to understand, all these technical things, and not shutting down and say, let's leave the IT people to do their things, especially since you say the clinicians have to be involved?
Well, I think Trish really made that point that the tools have to really be helpful. I mean, you've got a lot of work to manage cancer patients, and particularly, some of the points that Nadine was making about how do you link, the pathology results, how do you link the screening data, how do you, bring together all the information you need in one place. And if we build tools that are effective at doing that, I think that we will have a lot of buy-in from the clinicians, because we will save them a lot of time and potentially stress in dealing with that. Obviously it's got to be as usable as possible. And so, I mean, I think for a long time, we didn't have a great user interface in OpenMRS. I always wanted to be better. And now we have a great UI designer who does testing on this. And we try out all the different pieces very carefully. So hopefully that kind of process going forward. And we see this a lot with now new projects are working on improving information systems in low-income settings. A lot of the funded projects now require you to do these types of formative evaluation and also qualitative research around what are the requirements, what are the things that clinicians really care about or what they need, and then very carefully pilot testing and observing how they use. So I feel like in many ways that's probably as equally important to training as such, that the system should be as much as possible intuitive, which seems to be successful with the simpler system developed originally in Rwanda. That system was adopted pretty quickly.
Yeah, thanks. Yeah, I think, yes, I do agree with you that we should primarily make sure that the clinician who is dealing with a patient gets the most out of the system. I have been mentioning this as an observation that many of the information systems were sort of like top down. So there were people who are looking at aggregate, the ministers of health, the funding agencies asking for data, so that the system was designed to provide them data without so much support for the patient or the clinician who is actually entering the data, who has the burden of data entry. And yet, if you do that, in my opinion, if you support the clinician, that they get decision support, that they get their work made easy, then they provide the data that you can use for the for the upstream use of the data. So I think I'm in total agreement that we should make sure that the system is helpful for the individual clinician at point of care. I see Mr. Regis raising his hand or her hand, maybe missed or missed. So unmute and speak, Regis.
Yeah, thank you everyone. This was an interesting conversation, but I wanted to contribute on that last point. Yeah, I think involving clinician and in every single step of business analysis on what we are designing, it have been a key in our site where we have been showing the added value that is bringing in as now we are having a huge volume of patients across Rwanda and even beyond. Yeah, we have been showing them how the system can easier the day-to-day care by having things that are more populated on the user interface and involving them in designing clinical forms and understanding what they'll be looking as an output. Have been a key to have them being engaged so much quicker. And the other thing was like even to have the hospital's ownership have been a key to have them generate reports easily so that they can inform those reports can inform processes whenever the clinic are understaffed or the volume of patients are overloading clinic. Maybe if we need to add another clinic. On the other side from Botaro to easier patients not coming such a long journey to pick up only medication. Yeah, it have been a good experience. That's what I wanted to share. Thank you.
Thank you. Thank you. Are there other people who have questions? I feel like I'm taking over, which of course I can do since I'm moderating the session, but I also want to allow others to comment or ask or share their experiences. I don't want to call upon names. Well, if there are none, then I will also ask something else that I wanted to that came up. And this is something around interoperability and moving data between one system to another. Maybe from your side, Masvita, you mentioned that you have like this lab system and then you get the data into the registry. Is that done automatically, and how is that pipeline made? I know that Hamish talked about things like the interoperability, for example, OpenHIM allowing the mediation between data. And we are also having this same issue now in designing our systems. But I want to hear from your experience practically. How is the pipeline built for data to go from, let's say, the lab system to the registry? Do you use CANREG for the registry? How does the connection work?
No, we don't use CANREG. So the lab information system has it pulls all their individual lab information systems for each of the 265 labs of the government labs all over the country. They feed into the central data warehouse. But what we have done with the private labs, because I'm talking only about government labs right now, with the private labs, our IT team has worked with different private labs to structure all their reports in the same way that our report is structured. And this work was done a lot over COVID. That's when most of the work was done. We already had some labs that were onboarded, but over COVID, everyone now needed all we all needed them to be, all the labs, the pathology, the lab reports to have the same format so that we could do national reporting for the daily COVID stats. So this helped because now these labs are already onboarded. So, even labs like Ampath, Lancet, all these big labs, they all then dump their data onto the corporate data warehouse. It's pulled into our server, the National Cancer Registry server. And then we have an in-house app that was created by our IT team, the NCR app, that allows these reports to come electronically. So they read them, and then they have a drop-down menu to select which code it is. And that drop-down menu is pre-populated by the codes that already exist in the ICD-03. And it also has a section where to say if non-malignant, so that if the report is non-malignant, it's automatically taken out of the system, because we do not record pre-cancers. We only count invasive cancers. And it also has a section to exclude cancer reports that, because South Africa is a reference lab, so that means sometimes Swatini or Botswana can send some of their patients, for further supplementary tests on cancer biopsies. So those ones we exclude automatically. So if we see that this one is from Namibia, this one from Botswana, this one from Eswatini, there's a drop-down menu. South Africa, non-South Africa, anything non-South Africa we kick out. So that is the system that is used. Then it goes to a supervisor. A supervisor checks 10% of, because it's impossible for her to do all of them. She takes 10% of what everyone else has done to see if there are patterns of errors. And now we are trying to do double coding because we've caught up with the backlog, with reporting, so that 2 coders do code the same report. And then if they agree, we assume that it's correct. And if there is a conflict, then it helps also the supervisor to check. But generally, they are now good with their coding. The error rate is low, and sometimes they are just specific cancers that confuse them. But for the cancers that like cervical squamous cell cervical cancer is so common, breast cancer, they are very good with those.
Yeah. Thank you for these interesting experiences. I hear the need for a centralized place so that information from all the different places can go into one central place, and then you can be able to deduplicate and make sure you don't you don't count people twice. I also hear structuring the forms so that there is uniformity. As you mentioned, that each lab records the same piece of information as another, and I think that requires a lot of coordination on a national level. So I hear these important contributions. We are 5 minutes before before the end of this session, and it's very interesting, but we have to finish. I could keep asking so many questions, but we should stop here, and we can follow up on email. But I wanted to hand over now to Charles to give any closing remarks about the upcoming sessions or even this one. But before that, I want to thank you, our speakers, Hamish and Basvit, for your time. Thank you so much. This was very insightful, and thanks to the audience for joining. Charles, do you have any closing remarks?
So thank you very much, John Black, and I agree with you. It was quite an informative session. I personally have learned a lot, and I believe every one of us has taken home something. So thank you very much to our speakers and of course our moderator for the excellent session. So we are going to be sharing the recording on YouTube and also share the link on Basecamp and also the speaker presentations for our reference, because I believe we may need to refer to 1 or 2 things on the session. So look out for the recording in the course of next week. So our next session will be held on May 18th. And we are going to be looking at how the Africa Cancer Echo has been for the last 5 years, and also proposing what we need to do to improve this learning platform. So we look forward to having you then, and please come with ideas on how we can improve this learning platform so that we can even make it better and even get to reach more people. So thank you very much for attending, and have a good time. I don't know whether Mishka, you have anything to add?
Nothing to add, but just adding my thank you to all of you for this great discussion and a lot of things to consider. And then, as always, thank you to Charles for the recap you provide to us and all of the resources so that we can capture those moving forward.
Well, thank you so much. And yeah, I think, Hamish, we have to continue discussing and gathering people together so that we can see more of these technologies benefit patients and clinicians. So good afternoon, good morning, good evening, wherever you are. Bye.
Thank you.